All righty, well, thank you very much for having me. It's a pleasure to be here, and I do appreciate MEMC for inviting me, and Ed Sloan from FERNE for including me in these presentations. So we'll talk a little bit about intra-arterial therapy for stroke, and it really is an old story. There was a neurosurgeon by the name of Sussman in 1958 who did the first intra-arterial therapy. He had 3 patients who had stroke. He stuck a needle in their carotid, put a little dye in there, showed an occlusion, and then pushed a little bit of fibrinolysin, and then after that put some more dye in the next day, and then showed that there was recanalization. And one of the 3 patients actually came back to normal, and he noted that that was the one that was treated within 6 hours of onset of symptoms. So, you know, a few decades later, we kind of figured this stuff out. So in 1998 to 2007, there were 3 trials that actually showed benefit from intra-arterial therapy, and the way it was done then was that a microcatheter was actually placed directly into the clot, and the lytic was infused a little distal, a little into the clot, and a little bit proximal to the clot, and they would disrupt the clot with a guide wire. And the data had accumulated enough that even the American Heart and Stroke Association recommended intra-arterial thrombolysis back in 2007. So that was kind of the first generation of intra-arterial therapy. The second generation kind of came along as we had better equipment to actually go into the brain. And there were 3 kind of main catheters. One was the ECOS catheter that's still used, and many of you are familiar with it for large pulmonary emboli. And this is an ultrasound tip that actually kind of unwinds the fibrin in the clot and gives the lytic more binding sites, but the ultrasound generates a tremendous amount of heat. And the MCA is only about 3 millimeters big. So it did not work well for stroke. The other was the penumbra catheter, which is still being used, and these had advantages because they were much more flexible. They came in different sizes and could go out further. And they had a little guide wire with a little arrow tip that would pull the clot in and kind of disrupt it as you sucked it out. And then there was the MERC retriever, which is a corkscrew, and there are many editions of this that included little filaments attached to it that would bind the clot. And then the idea was, you know, you would put a proximal catheter in, occlude the artery, suck blood, the clot, and pull on it and bring it back, and then establish recanalization. The thing is that these kind of got out into the public before really trials were completed with it. So when people looked at combined intravenous intra-arterial therapy, and all this is still in the 0 to 3 hour window or in the early windows, it was, it actually proved not to work that well. So soon as the TPA stroke study was done, the investigators started looking at doing this combined approach. And in 1999, the EMS bridging trial showed it was feasible. After that, major trials were undertaken in various time windows, but pretty early on in the stroke. And then in 2013, all 3 major trials showed no superiority of the combined therapy IVIA to IA alone, and to IV alone, I should say. And so this basically shut down all sorts of intra-arterial therapy programs, and these had gotten out into the public, and people had already started building intra-arterial therapy programs with this and advertising for it, but it actually made everybody reset at that point. So this was like a big kick in the pants. So we learned some lessons. So it took a long time to conduct trials on equipment that had already been let loose out in the public, because people were saying, don't go into the trial, we'll just treat you with this device. We needed better equipment than we had. We needed to select people better than we had been selecting them for, and that we found that time is brain. However, collaterals do matter. So then came along the stent retriever, and the stent retriever is a really interesting device because you put a microcatheter through the clot with the stent inside the catheter. And then as you pull back the catheter, the stent opens up in the clot and actually almost immediately creates a central channel that allows blood flow to come back. So you're not in there for 2 hours, you know, trying to corkscrew the clot out. And then the stent sits there for about 10 minutes or so, and the clot starts to bind to the stent a bit, and then you occlude the artery and pull the stent, the clot, and all the blood gets sucked out with it. So you kind of reverse flow in that area for a few seconds while you're pulling the clot out. So there's two major companies, the Solitaire and the Trevo retrievers, that are being used. So in initial trials, when the Solitaire catheter went up against the MERC catheter in an 8-hour window, it actually showed much better recanalization rates, better mortality, and better symptomatic hemorrhage rates. And so these trials were required by the FDA to show that the new stent was similar to previous equipment that was being deployed in the brain, but it was never required to show efficacy in terms of patient outcomes and improvement. So in terms of patient selection, we had been working on this aspect score really since the early 90s in the Calgary group. And for those that aren't familiar with the aspect score, you use two slices of the brain that show the middle cerebral artery distribution. And there's 10 regions that you look at, and you get 1 point for every region that's normal. So that if you're a 10, everything is normal. And there's no signs of early ischemia, edema, or hypodensity in any of those 10 areas. So if you have a score that's 8 or greater, you have a really good chance with therapy to come back to functional independence. And the lower your score is on this, the worse your chances are of gaining independence with therapy. The other thing that came along is CT perfusion. And CT perfusion really showed that you could see what the infarcted tissue already consists of. So a cerebral blood flow of less than 30% lesion on MR, and the DWI lesions were thought to be already dead brain. And then the ischemic area just had slow flow. So if you had the time up to peak concentration of contrast through your brain of 6 seconds or more, that slow flow was considered ischemic, but not infarcted completely. So if you subtract the two, you get what your penumbra should be. So this is an example of a good mismatch, and so a person has a large area of ischemia, and that area of ischemia, the neurons are silent, so that's the deficit that you produce. And then a smaller area of infarction, and that's more permanent. So this would be a good candidate for intra-arterial therapy. On the other hand, if you have a match deficit where you have a large area of ischemia and infarction and the deficit is matched, then you think that's already a completed stroke. So we know that time does matter with this, and that the longer you wait to reperfuse, the worse your outcomes are. So reperfusion and time are also related, just like thrombolysis and time. The other thing that we found was that there are people that progress to infarction at different rates, and this often relates to how good their collaterals are, so that there are slow progressors, intermediate progressors, and fast progressors. And so some of these people progress at relatively slow rates, so that by the time they actually present, you can figure out what's going on with them, then you still have time to treat them. And so understanding that there are slow and fast progressors is really a very important thing, because the slow progressors have a bigger time window and a better tissue signature on the patient selection mechanisms. So then 5 major trials came out in about 2015 or so, and they're MR or Mr. Clean, Escape, Swift Prime, Extend IA, and Revascat. And Mr. Clean was the first to report, and it was revolutionary, and it forced all other 4 trials that were ongoing to actually shut down and analyze their data. And so all of these guys shut down, did their interim analyses, and they were positive at that point, so they did not continue. So they didn't reach all their planned enrollments. So in 2015, all these trials were positive. They used better selection criteria for patients. In general, their time window was about 6 hours or so. One of them went out to 12, one to 8, but they were generally in that 6-hour range. They treated very severe strokes with stroke scales of 17 to 18, and they had various results. but between 35 and 70% of these people ended up independent at 90 days. And with thrombolytics, if you have a stroke scale of 20, your chance of being independent was about 10%. So this was a major advance. So then the window was extended for intra-arterial therapy with 2 trials, the diffuse and DAWN trial. And these trials use CT perfusion, and so these actually worked really well. So diffuse went out to 16 hours, and it showed that 44% of people versus 16% came back to independent function at 90 days with no increase in hemorrhage or mortality. And then DAWN came out, and the DAWN criteria now for CT perfusion are used by most centers around the country, and they showed a remarkable 48% versus 13% of a Rankin score of 0 to 2. So 0 to 2 is a score where you can actually resume all your previous activities even if you have some slight disability. So beyond 24 hours, there was the SELECT late trial now that actually has reported out, and it showed that even if you go out beyond 24 hours, there are some people that will still benefit. The Rankin score of 0 to 2 was achieved by 38% beyond 24 hours versus 10% without an increase in symptomatic hemorrhage or mortality. So these people are clearly, you're very slow progressors, and they have some time to actually improve from reperfusion. Then the next big issue was, we're using CT perfusion to say these people with the large cores and this big matched defect are already done. But is that really true? Has that infarct really been completed, or can you still get some benefit out of it? So these people were generally excluded from all the trials because the common wisdom was that they're going to be at really high increased rate of hemorrhage and that they'll have a poor outcome no matter what you do with that big a core infarct. And so these people were enrolled into trials if their aspect score was 3 to 5, which is very low, if their CT perfusion core, which is less than 30% predicted perfusion or normal perfusion of 50 cc's or more, and MR perfusion of 50 cc's per more or more. And lo and behold, they did better. And so these people that we thought did not have much hope with the big infarcts or the fast progressors also can do this. So there are 3 trials, Angel Aspect, Select 2, and Rescue Japan Limit, and they all showed an improvement in the Rankin score at 90 days with intra-arterial treatment. Hemorrhage rates were not different, and mortality was not different. So this really expanded the population that you can go ahead and treat, and this is one of the things that to me was a real lesson, because you looked at those CT perfusions and you thought this patient is not going to do well. So it just goes to show you never know till you know. So then there was also a meta-analysis of 14 large trials or large core trials. And actually, your odds ratio for coming back to functional status was almost 3, with no increase in symptomatic hemorrhage, no increase in mortality. So now, the last thing that actually people looked at is how far out can you go to pull clots out and have a benefit? And it turns out, not all that far, because when you look at medium-sized vessels, which is the M2, and then the distal vessel, which is the M3, so distal parts of the middle cerebral artery, the vessels really get very small. So you may be talking about 1 to 2 millimeter size vessels that you're trying to deploy equipment into. And that can be very challenging. So 3 recent trials reported out at the International Stroke Conference in February, looking at medium and distal vessel occlusion, and all 3 of those trials were negative. It was the ESCAPE MEVO. MEVO is the word for medium vessel occlusion, distal for distal occlusions, and then there was a trial called DISCOUNT. And actually, DISCOUNT was shut down during a safety interim analysis because of an increased rate in hemorrhage. So none of these trials showed benefit, and ESCAPE showed an increase in mortality, and all the trials showed an increased risk of hemorrhage. And I think that's really not all that surprising, because you are deploying equipment and stents and stuff into, really small vessels. The other thing, though, that's kind of, well, I'll get into that in a second. So now the next thing is, do you bridge or not bridge? And what bridging refers to is, do I give you TPA or TNK while you're waiting for your intra-arterial procedure? And that starts things going. And so right now the guidelines are, yes, you do that, you use both, and you don't delay. And there's a meta-analysis done a couple years ago of 6 large trials that showed that going direct to intra-arterial therapy did not meet criteria for non-inferiority. So that's a little bit of a goofy way of saying that it was not as good as using IV TPA plus intra-arterial therapy. So recently published, just this few months ago, the 2025 Bridge TNK trial. And this was done in China. And when they actually did combined therapy, they had a 53% coming back to 0 to 2 on the Rankin versus 44%, no increase in hemorrhage and no increase in mortality. So using combined therapy is very important. And I think that now that we're using TNK, it'll be more important because TNK starts to work right away. A lot of these studies with TPA, they would give the TPA and then 10 minutes later, start the intra-arterial procedure, but the infusion still had, 50 minutes to go. So now the timeless trial looked at this going out to 24 hours. And the idea was, can you safely give TNK out to 24 hours while the patient is waiting to get their intra-arterial treatment? And this was a negative trial. But the secondary outcomes were interesting. So there was better full recanalization at 24 hours. And for people that had only a M1 occlusion, they had better outcomes. So those people in the secondary analysis had 46% came back to a 0 to 2 Rankin versus 31% without increase in complications. So then now the next thing that people are really working on is to verify those timeless results in different studies and see if you can go out to 24 hours. But then there's a slew of all these adjuncts to intra-arterial therapy. So much like when you have an acute MI and you start people on heparin, aspirin, Brilinta, and everything before they go, you may have to do this in the emergency department and start some treatments before they go for intra-arterial therapy. And I won't get into each one of them in the 15-minute window, but when you lump them all together, there is a clinical benefit to doing adjuncts to intra-arterial. So what does this mean for emergency physicians? So I think we have to, be very expert at the rapid evaluation and management of stroke patients, and I think we have to work with EMS systems to say, is this a stroke? Is this a large vessel occlusion? And we have to get involved in creating protocols, transport agreements, and all this other stuff. The American Heart has a protocol for what EMS should be doing. But the thing is that right now in emergency medicine, we really are feeling like, oh, this is going the way of acute MI. Everybody's just going to go to the cath lab and we're not going to have to do anything. Well, that's really not going to pan out because only 10 to 12% of patients have a large vessel occlusion. And you still have to take care of all these other patients with stroke. And on top of it, only maybe 20 or 25% of patients actually end up getting acute treatment. So stroke is not going anywhere for emergency medicine, and we have to really get involved with it, and we have to get involved with our pre-hospital protocols as well. So I can stop here if you like, or I have a few more slides to fit. Okay, so the real question that people have been asking a lot is, if you're going to create protocols, which pre-hospital severity scores do you use to determine if it's a LVO, and where do they go? And you can see that all of them are performing relatively the same. So the best ones are the stroke scale, which is too long for pre-hospital care, RACE, GFAST, and LAMS. The Los Angeles Motor Score are really the ones that have the the best predictive values. And then the question is, when do you actually ship them and how far do you ship them? So if you're in an urban area and you're within 30 minutes of a comprehensive or a thrombectomy capable hospital, you ship them. If you're in a suburban area, you know, it may go out a little bit farther to 45 minutes before you ship them. And if you're in a rural area, you try and get them there within an hour. But the thing is, in the United States, these thrombectomy capable and comprehensive stroke centers are not available to all our population. So I think this also says that early treatment with thrombolytics, you know, can actually help in these extended transports and give people access. So there are other ways of doing this. Some people say just ship everybody as fast as possible to a center that can give the lytics, and then ship them after that. And so that's another strategy that works also, as opposed to diverting ambulances. So in summary, intra-arterial therapy for stroke is going to continue to evolve. We need to keep up with it. Bridging and combined IVIA therapy, I think, are very important. Adjuncts are going to come underway that we need to keep up with and we may have to administer, and that emergency physicians are all a critical part of these systems. So it's really important for us to actively participate in their development. Thank you.